Good afternoon. Edgar Bumanis with Bryan's advancement team. Thank you for joining us. Joining us today, we have three physicians, Dr. John Trapp, Chief Medical Officer for Bryan Medical Center, Dr. Amy Pinkall, pediatric hospitalist, and Dr. Sian Jones-Jobst, pediatrician. Before we begin, I'll quickly go over some Bryan Medical Center patient volumes. In the last month, we've actually hit record census of 588 on 2 occasions. At midnight today, we were caring for 571 patients. Pediatric census, the unit is full, 6 patients with RSV, 2 with COVID, and 7 with non-respiratory needs. COVID, our census is fluctuating between 15 and 25 per day. Today, we have 12 with positive COVID tests, 7 who are resolved, and 9 patients with pending tests. And this last slide is a good segue to our first presenter, Dr. John Trapp.
Thanks, Edgar. I really want to focus on the volumes in the hospital. During the peak of the pandemic, it was not uncommon for us to hit numbers of 530 patients, 550 patients, and sometimes peaking up in the 570s. Here in the last few weeks, we've seen even higher census where we're consistently 550 to into the 580 numbers. This is a considerable expansion of the hospital capacity, a stretch on our workforce. And what we're also seeing is increased volumes in our emergency department. We've tried to expand our emergency department capacity the best that we can. We have expanded to hallway beds so that patients are still able to be evaluated, and certainly emergency room volumes are higher than what we've seen ever in the past. What all of this means is that getting into the hospital at Bryan Health has been challenging because of our high volumes. It's not uncommon for us to have patients waiting in the emergency department for a bed to get onto a medical unit or a surgical unit, or for patients at outside facilities awaiting transfer to Bryan. All of this comes at the same time that we have concerns for other types of viral issues coming up. We've seen increases in RSV in our pediatric population. That's been a concern. Last week we had 27 pediatric patients in a 17-bed pediatric floor. So we've had to expand that to some of our adult floors. RSV peaks over the next few months, so we will be expecting continued pediatric RSV cases during the months of November, December, and January. RSV not only affects pediatric patients, but can affect adult patients as well, particularly those patients who are 65 and older, and certainly can cause significant hospitalizations and even death in those populations. So we expect to see higher patients with those types of respiratory viruses. For our COVID patients, we've been having a very steady census of COVID patients, anywhere from 15 to 30, as Edgar had outlined. Some of the concerns about COVID is that we've seen some new variants that have developed throughout the world. 2 of these variants, BQ1 and BQ1.1, are 2 variants that have increased significantly in the United States. We've seen significant rises, particularly in the East Coast, where this is increasing numbers in excess of 20%. This virus has a doubling time where it increases in the population over about 10 to 14 days. It's in the Midwest and increasing. If we look at projections, and again, during the pandemic, we saw significant waves of new variants. And what we saw in other areas of the country and across the world eventually made it to Nebraska. So we're anticipating these waves probably hitting Nebraska in late November and through the month of December and maybe into early January. So that these variants have resulted in increased hospitalizations and deaths in other countries, and we anticipate that same risk for us. So here we are in November. What comes in November typically? Influenza, another respiratory virus. And this year, influenza seems to have started a little bit earlier, maybe by 6 weeks or 8 weeks earlier. Typically, we follow waves of influenza that are seen in the southern hemisphere, and now we're starting to see increasing numbers of influenza here in the northern hemisphere, which includes the Midwest. If this is a typical influenza season, we're going to continue to rise over the next 4 to 6 weeks, and so we expect to see peaks of influenza cases requiring hospitalization and utilization of resources, again, likely in the same period, late November, early December, and probably stretching through into early January. So what does this mean? This means that our hospital capacity is going to continue to be strained. We're going to see high volumes in our emergency department and need for patients to be hospitalized because of these respiratory viruses. And this is a concern. With regard to RSV and our pediatric population, we are meeting with our Region 7, which includes Nebraska, Kansas, Missouri, and Iowa, to really understand how our capacity is and how we can access pediatric intensive care services for patients who might need this, as well as other hospital beds. Our team works closely with Children's Hospital, and you're going to meet 2 of our pediatricians today that help facilitate some of that work. What can you do about these viruses that I've just mentioned to you? What I think is important for you to be thinking about as a community is there's still time to get your COVID booster. The bivalent booster that's out currently does seem to reduce the severity of illness and risk of death related to these new variants that are out there, as well as get your influenza vaccine. Again, after you get your vaccine or booster, it takes a couple weeks for it to have the maximum effect. If we anticipate these viral loads increasing by the end of this month, you do have time. So my encouragement is for you to get boosted with your COVID-19 bivalent booster and to get your influenza vaccine. Thank you for the time.
Thank you, Dr. Trapp. I'm just going to touch a little bit more on RSV infection and RSV bronchiolitis that we're seeing here in Lincoln and really across the nation. So RSV is a virus that causes infection, and it's common in all ages, as Dr. Trapp said. Most children are going to be infected with this virus in the first 2 years of life. Older kids and adults tend to get cold symptoms, typical runny nose and congestion. But younger children, especially those under 2, can become more ill with what we call bronchiolitis, and they can have much more severe symptoms. So they'll have fever, coughing, increased work of breathing, hard time catching their breath, wheezing, low oxygen levels, high carbon dioxide levels. And we see that most especially in babies who are of a younger age and that were born prematurely, or children that have underlying health conditions such as heart disease or things like that. And we've been seeing record numbers of RSV, as Dr. Trapp mentioned, and we're seeing it much earlier and much more of it than we have seen other seasons, and we anticipate that it will continue over the next few months. Additionally, these children have been more sick than we typically see with RSV. We've had more children needing transfer to intensive care units, such as Children's Hospital and Medical Center, and that's been difficult for our babies. Unfortunately, there's not any specific treatment for RSV infection. It's really supportive care. So we can give people oxygen, we can give breathing support, we can give IV fluids or tube feedings to help support their hydration and nutrition, but no medicine per se to make it better. Sometimes people ask about things like breathing treatments or steroids or antibiotics, and unfortunately none of those are going to help our kids get better faster. So we expect to continue to see these high numbers of RSV, and we really hope we can prevent some of that infection. There is no vaccine currently for RSV, so the best methods of prevention are avoiding sick contacts, good hand washing, keeping your child home if they're sick, and otherwise staying generally healthy. So being fully vaccinated for other illnesses may help prevent that co-infection with other illnesses like influenza and COVID. All right, Dr. Jones-Jobst.
Thanks, Dr. Pinkall. So I'm a general pediatrician in the community, and we are seeing quite a bit of RSV right now in the office, along with many other respiratory viruses, some enterovirus, human metapneumovirus. It's not uncommon, actually, when we do have kids who are seen in the emergency room and do get a viral panel, that they have multiple viruses, 2 or more at the same time. But quite a bit of what we are seeing is RSV. We are filling our same-day sick appointments in the office, which is unusual this early in the season. Usually that's something that hits in late November, early December, and through January, February. So it's definitely been an earlier rise, and we are starting to see some influenza as well. So as Dr. Trapp and Dr. Pinkall said, please get your influenza shot. That will help to prevent some of those dual diagnoses of different viruses, which tend to be more significant. In the office, we want to see your child who has increased work of breathing. Maybe they sound like they're wheezing. They might have what we call retractions. So when they breathe, their chest collapses a little bit because they're trying to get air in and they can't get air in. And so their chest collapses instead. If they're having a hard time staying hydrated, most babies with RSV bronchiolitis and young children with RSV bronchiolitis have a hard time staying hydrated because it's more difficult for them to eat. That's another reason to call your doctor's office or to have them seen right away. And definitely if they're very irritable, fussy, or perhaps have a fever. In children less than 3 months of age, if they have a fever over 100.4, we want to see them in the office and make sure they don't have something in addition to a cold or a viral URI. We also want to see older children, older than 3 months of age, if they have a fever over 104 or a fever that's lasts for more than 4 days, or perhaps a fever that's hitting at the end of an illness. It's not unusual for children with RSV and other respiratory viruses to have secondary bacterial infections like ear infections or pneumonia. So those are the types of things you want to be watching for. When babies come into the office, you can expect that they may have their oxygen levels checked. We're going to count their respiratory rates and watch to see how fast they're breathing and listen to them. There's no particular treatment, as Dr. Pinkall said, for RSV, but really what we do is teach parents to do supportive care at home. Most babies with RSV bronchiolitis can be taken care of at home. They just require humidity to keep the mucus moist so it can move in the airway, frequent suctioning to keep that upper airway clear, and usually smaller volume feedings. When they come to the office, one of our most important jobs is to see how well they're breathing and make sure that if they do need transfer to the hospital for more intensive care than can be given at home, that Dr. Pinkall can take care of them. So, and her crew, who we very much appreciate. I would say there are some times where RSV bronchiolitis could be an emergency at home, and it's definitely something that you want to take them in right away. Definitely if you have a baby who's extremely lethargic, not waking up for feedings, or appears like they're not trying to breathe very hard, that's a late sign that we really have some complications from RSV, and that's a reason to take them in. And of course, if they have blueness of the face or the skin or the lips or the fingernails, or if they look like they're struggling to breathe and they can't get air in, or you're worried about dehydration. So any of those might be a reason to take them in right away. We don't have a vaccine for RSV yet. And so right now, one of the best things that you can do is to wash your hands, stay home if you're sick. If you have to be around others and you have symptoms of illness, it does help to wear a mask. It does prevent spread to others with that source control. But RSV is really spread person to person and from contact with surfaces that are contaminated with the virus. So keep your hands away from your face. Don't allow children and people to share beverages, to share things together. Even wiping down toys frequently if you have kids from different households that are sharing toys can help to prevent the spread of RSV. If you have a child who's at higher risk of complications from RSV, as Dr. Pinkall mentioned, somebody who maybe was born very prematurely or is very small or still very young, less than 6 months of age, or has a heart defect and they have more difficulty breathing, those are kids kids that you want to try to avoid going out in group situations. Oftentimes I'll tell new moms and dads, this is a great time to let individuals come to your home and say hello, kick them out if they look like they're sick. Even if Uncle Tom says it's just his allergies, maybe he should not come to the house until he's got those cleared up. And then keep your baby, either wear your baby in a sling or a wrap, or keep your baby in a carrier, because people are less likely to try to help you by carry your baby or pass your baby around. So those are things to try as well to help prevent the illness. Probably one of the best things that you can do is get your vaccine for influenza, COVID, and I'll put a plug in there too for whooping cough or pertussis. We definitely don't want to see children with RSV if we can avoid it, but even more so, we don't want to see children with RSV and influenza, or RSV and COVID, or RSV and pertussis. And so the best way to protect young infants from these illnesses when they're too young to be vaccinated is to go ahead and vaccinate everybody around them. Children 6 months and up can get a flu vaccine. Children 6 months and up can get a COVID vaccine. And everyone should get their pertussis series. All the adults in the household should get their Tdap if they haven't had one in the last 10 years. So that's probably the main things I'll mention today. I did see there's a question about an RSV vaccine. We have had exciting news in the last week. There is a potential RSV vaccine that Pfizer has said that they're going to submit to the FDA sometime before the end of 2022 for approval. This is a vaccine not for children for RSV, but for pregnant mothers. So the idea is you give the pregnant mother the RSV vaccine, they develop antibody, it passes to the infant, and then when they're born, which is at their highest risk point for having complications from RSV, they should have antibody on board. It looks like it was about 80% effective in preventing severe RSV and hospitalization, and about 50% effective in preventing RSV infection itself. So that's great news for those of us who take care of some of these infants, but we don't have it yet. So we'll have to stay tuned for that.
Thank you, Doctor. The other question already submitted through chat deals with the high numbers of RSV. The question is, could it be because people kept their children at home more and they weren't able to build up immune systems to fight RSV? Excuse me.
Hi, I'll just speak to that question. That's a good question. Probably not related to them being home and not building up their immune system. RSV is a virus that we see every year all the time. There's different strains of it each year, and some years it's just more prevalent and more virulent, and this just happens to be one of those years. And most of these children that we're seeing with the severe infection are under 2 years of age and even under 1 year of age, so they haven't been around to be exposed to RSV prior to this.